This question. For acute leukemia, there's still a lot of improvements to be gained for the outcome, and that is because, for these patients, we usually give systemic chemotherapy, and most of the times we can achieve for them a complete remission. However, after this complete remission, sometimes some cells remain, leukemia cells, and then they develop a relapse. And since a relatively large proportion of patients develop such a relapse, we should really focus on preventing it, because when a person already has developed a relapse, it's very difficult to cure, because these are notorious drug-resistant cells. So we do a lot of research based on new drugs with new mechanisms, drug resistance mechanisms, and of course also monitoring these persistent cells. And that's called measurable residual disease. And when a person has a level of MRD above a certain threshold, usually 0.1%, then they have a relatively high risk for relapse. And these assays usually only measure the bulk of the leukemic stem cells, but we have been focusing on looking at the leukemia initiating cells within that residual cells, and we think that those are the leukemia stem cells. And for that, we have developed a one-tube assay that you can incorporate in your flow cytometry analysis, and then you can also measure the stem cells. And we have already shown in a retrospective study that these are having a highly prognostic value. And we are currently validating this in a prospective study of the whole 132. So yes, we do think that there is a lot to gain for these patients for preventing the relapse. Our recent research progress, the main thing that we are currently doing with respect to these stem cells is that we incorporate them in this MRD assay, and that we are testing whether these have prognostic impact. So that is one of our important improvements of MRD, but there are of course a lot of more research ongoing for the improvement of MRD, such as what is the best time point to measure MRD, the cutoff levels to measure MRD. So that's actually where we are focusing on now. And these type of studies are not very easy. So you need a lot of patients to also have an idea of the research, the relapse risk in these small subgroups. So we do a lot of collaborations nowadays. For instance, in the European Leukemia Net, that we have a lot of working groups, especially the MRD working group, Ela and David, that we recently set up. And also, for instance, in initiatives like Harmony, where we combine all these types of data in order to have a better sight of the risk classification for patients and possible new therapies. So for MRD, we really shown now that for the intensively treated patients, this MRD is a very important prognostic factor. But that is mainly for the intensively treated patients, and then especially for the intermediate risk patients, because if they are MRD negative, they can get an autologous stem cell transplantation and be spared this more intensive allogenic stem cell transplantation. But this is how this works out for patients that are not intensively treated is not yet clear. So a lot of research is based on that. And when we look at MRD, then we see that still about 30% of patients, or no, I'm saying it wrong, that patients who are MRD negative have about 30% chance of getting a relapse. So that we are not doing perfect yet. So we have to improve. And of course, we do a lot of research trying to improve that. For instance, we look at other time points, other cutoff levels. Maybe we get false negatives because of the hemodilution that might take place. And we notice, of course, that molecular aberrations are key. So the combination between flow cytometry, stem cell measurements, and molecular techniques, and especially the novel techniques, including this next generation sequencing, hopefully we will improve MRD by these novel implementations. In general, it has been suggested that children are more susceptible to chemotherapy and they can endure higher concentrations of the drug. That might be in part true, but on the other hand, adult patients and especially the elderly usually have this more resistant leukemia with very specific molecular aberrations, and that also makes them difficult to treat, and even in combination with other comorbidities. So that is one of the reasons that elderly patients can be difficult to cure. However, in children and in adults both, still a lot of them will be developing a relapse. And when a relapse occurs, maybe children can be salvaged a little bit better, but usually that is the most difficult in all the age groups to salvage and relapse. So for both research groups, it is very important that we aim to prevent the relapse. And for children, of course, MRD is important. And we have shown that if you look at the stem cell loads in children at diagnosis, it's already a prognostic factor. So we are currently looking into the stem cell load in children during therapy and see if that is improving the risk stratification also in children. Yeah, and we hope, of course, that when we characterize these leukemia stem cells, that we can know more specifically in a more individualized way how to target them. So not only the surface markers, that's where we are more specialized in, so that you can have targeted therapies, not only to a certain marker, but nowadays even to more markers. But also molecular targets and mutations. So it's a thrilling new future for possible therapies. And with these stem cells and stem cell MRD, we hope to contribute to that. Thank you. It is indeed, it is very important to eliminate leukemia stem cells to really cure the patient, so that no relapse can occur. But as with most cancers, leukemia stem cells are thought to develop from their normal counterparts. And their normal counterparts, the hematopoietic stem cells, are of course key for the survival of the patient. So it is a thin line that the hematopoietic normal stem cells have a lot of features in common with the leukemia stem cells. So you have to be really careful to target only those qualifications that are present on a leukemic stem cell and not on a hematopoietic stem cell. That might be difficult, and therefore there are also in the article several therapies mentioned when they try to target several markers. So the combination of double or triple targeting antibodies to really specifically target the leukemia stem cells. So that might be very important. And the other feature is that we have seen that the especially acute myeloid leukemias are highly heterogeneous, even at stem cell level. So if at the stem cell level you might eliminate one clone, there will be other clones. So it will be important to have, for instance, combination therapies or to characterize the disease in each individual and then see what subsequent target therapy to give. So there are a lot of options, but it is still difficult, and especially because the stem cells are so have so many things in common. So yeah, a lot of research, especially one of the co-authors, she is assistant professor here that we asked as an expert for this review, Linda Smith. She's looking, for instance, at all these new leukemia stem cell markers and targets so that we can develop new therapies. And for instance, the senior postdoc Costa Bajas, he's really looking into this clonal evolution, because we know that if you look at a diagnostic sample, it can be completely different from the relapse. So if you only look during therapy at the markers that were there at diagnosis, you can miss a lot. So that's also an important feature. So yeah, I think in the future we have to find more specific targets. And also what we would like to do is really look at these biomarkers and upfront select patients then based on the biomarkers that would benefit from a treatment, and also maybe those who would not benefit from the treatment if they don't have these biomarkers or may have biomarkers of resistance. And the other thing that is very important is that we are thinking or that it might be possible to use MRD as a surrogate endpoint, because now you have all these new therapies, also leukemia-specific therapies, but you have to wait for years to look for improvement in survival. If MRD would be an endpoint of effectivity of the new drug, that would be really, really helpful. So this research into the intermediate or surrogate endpoint levels of MRD and stem cell MRD, that might also be a game changer. So that research is also highly interesting. And while I was mentioning every other co-authors, I also should mention that all this research work of the paper has been done by Quinty Hansen. She is a talented Master Oncology student. So we are very proud of all the things she found to have a nice overview of what's going on at this moment. I think I already mentioned it in the last question, but I think it is really, really important now to have a good risk classification. I think that we have seen in the last years that outcome improvements has come from understanding more about the heterogeneity in AML. So not every patient is the same. And you can already at diagnosis discern some kind of combination of mutations that are highly explaining the risk for a relapse later on. So the better you can classify your patients based on a certain risk of relapse, the better you can already start with specific treatments. So you will see in the literature that is a dynamic phase. So you always think, now we have now a risk classification and it's written in stone, but you will see that there is always improvements there. So we will have a new risk assessment by the ELN this year. So there's a lot of improvements still ongoing there in the risk classification already. And then, of course, in characterizing the disease, monitoring the disease, even monitoring the disease, for instance, after stem cell transplantation, because if you see some MRD upcoming, maybe even MRD relapse, you might interfere in an early stage. So these things will become highly important, I think, in the near future. And I think that we will get there with a lot of collaboration all around the world.